Welcome to Leadership Chats with Dr. Wise, the Not a Lecture podcast where we explore what it really means to lead in today's complex healthcare environment. I'm Dr. Wise, and in this series, we're having real conversations about essential leadership concepts. We'll talk about what you need to know, what you want to know, and what you'll actually use in practice. And yes, what you need to know to pass the exam. Each episode, I'll be joined by a guest expert who brings real-world experience and insight into nursing leadership, from managing care teams to fostering a culture of safety and everything in between. Whether you're listening on the go or settling in with your notes, this is your chance to deepen your understanding and connect what you're learning to real-world practice. No slides, no lectures, just meaningful conversations that bring leadership to life. All right, welcome to Leadership Chats with Dr. Wise. Today, we're talking about one of the most important foundations of healthcare, creating a culture of safety. I'm joined by Joe Don Cavender, Senior Vice President for Clinical Design and Transition Planning at Children's Health, a large pediatric hospital network in North Texas. Joe Don has decades of nursing leadership experience, including serving as Senior Vice President and Associate Chief Nursing Officer at Children's Medical Center Dallas, and he's dedicated his career to operational excellence, safe patient care environments, and supporting staff well-being, all very important topics. He also created the Safe to Heal Triad, a framework for preventing workplace violence and supporting safety at every level. As you're preparing to step into practice after graduation, and maybe even thinking about your role as a nurse leader down the road, this episode will really help you connect classroom concepts about safety to the realities of practice. So let's start chatting. Welcome, Mr. Cavender. It's good to have you on the show today and to join this conversation. And why don't you start by telling us a little bit more about yourself?
Yeah, sure. So I started here at Children's as a new grad nurse in 1992. I started in 91 as a pediatric nurse tech. That was essentially the precursor to a patient care technician. And had an associate's degree, went back to school and got my bachelor's, and then recognized that I wanted to be a nurse practitioner. And so went back to school and became a pediatric nurse practitioner in 99. And then just by fortune and being in the right place at the right time, I was uh, put in the position as the director of the advanced practice service. So I grew that from 88 nurse practitioners in 2005 to about 450 when I transitioned them over to UT Southwestern in 2019. So I just have had the opportunity to do lots of different things here at Children's, and just it's been a great place for me, and just grown and lots of it just seems to always be the right place at the right time. Like now being on this design of our new pediatric hospital, it's just really a good opportunity for me to hopefully finish out my career.
That's so awesome. And I like that you point out, I think there's a lot to be said about being at the right place at the right time and knowing the right people too. So,
Yeah.
a good little side caveat for our students is to be a go-getter, show up in places that people may not expect to see you there, and get to know people, build your network, and you never know what that can turn out to be in the future.
Yeah.
So
Never
that,
be afraid of learning. I
yeah.
knew nothing about architecture or construction really, other than minor things around my home. But that's I mean I had to become steeped in all of that terminology. It's a whole different profession, obviously, and um, that and I didn't mention, but I'm in the DNP program at Texas Tech, and hopefully it'll finish next May. Well, not hopefully, I will,
You
but
will, of course.
got a lot of work to do between now and then. But it's good.
Yes.
It's fun.
That's so awesome. That's so awesome. And yes, you are working on a very large project right now. So
Yeah,
kudos to you. And I bet that new challenge is actually a little bit fun deep down inside. So
it is fun. Very rewarding.
awesome. Well, let's start off by highlighting and defining what a culture of safety is. So we often use the terminology culture of safety, and I feel like it's more recently become kind of an official terminology for what we know as environments taking a multifaceted approach to safety. So from your perspective, what does culture of safety really mean in practice?
Sure. Well, really, for me, a culture of safety is really a shared mindset. It's a shared vision where safety is always first for our patients, for our families, and for our staff. It's not just checklists, it's not just our policies, but it's really transparency, psychological safety, shared responsibility. We're all in this together. We're all trying to keep each other safe. It's also about a just culture, or sometimes now called a just and fair culture, which really is, human error is consoled, at-risk behavior is coached, and then reckless behavior, then you're held accountable. But it's also a process where factors are evaluated, and blame is not just placed on the individual. It's
Mhm.
really about rooting out, and we'll talk about that, I think, a little bit later, more in depth, but it's really about rooting out what those system issues were that really led to the failure or didn't support the nurse to be safe and be able to make good decisions.
That's a good, helpful way to describing what it means. I mean, I think it's a really broad terminology that encompasses a lot. It's not just, making safe decisions or doing safe things. It's that safety is intertwined into every aspect of practice, and that we're constantly evaluating how to be more safe in the process because I think there's always opportunities, even when we get to a high achieving level where safety is going great. We still need to be open to opportunities for improving safety in the environment. So that's a very helpful
Yeah,
definition
it's
to.
a learning culture.
Yeah.
You have
Oh,
to learn
absolutely.
from your near misses or your errors and figure out ways to prevent those from happening, make
And
everything
that's,
safer.
yeah, that's a great point. And that's a mindset that everybody has to embrace. So, what factors do you see as most essential for building and sustaining a strong culture of safety?
Yeah, I've touched on these things just a little bit in that first description, but it's really transparent reporting without fear. So people have to have that psychological safety where it feels safe to speak up, and you know that you won't be harmed by sharing a near miss or perhaps an error that you made. That it's not the end of your career or the end of your ability to care for patients and do what you love. It's an opportunity for us all to get better and learn, and for your colleagues to be safer than what you were. And then it's really leadership. I think, for me, that was always important is, I would say I was on call, 24/7 for probably 10 years. And I'd get calls, in the middle of the night. And I learned very quickly the very first thing when you get a call is, hey, thank you so much. What can I do to help you? Right. It's this welcome response that's reassuring, that says, hey, we can figure this out. We've got this. We're going to work together. It's really that appropriate response to mistakes. Oh gosh, I'm so sorry that happened. Tell me what happened. Let's see what we can do, to make this better. And it's really not. It's looking at system and process fixtures, and not really individual blame. So it's really an avoidance of keeping everything onto a sole individual, which none of us really come here with the intent or even want to bear that kind of responsibility. And then it's really that ability to stop the line and stop the line in a very safe place. If something doesn't feel right, it's incredibly important to say, hey, look, this doesn't feel right. I'll give you an example. We had a nurse practitioner actually in one of our operating rooms a few years ago, and the surgeon was going to implant a mesh for a hiatal hernia, and she said that's the wrong type of mesh. There's mesh that can support the esophagus, but there's also mesh in other places where you use it to create scar tissue, so that for like an inguinal hernia, so that it doesn't protrude again. And she said
Mhm.
that's the wrong mesh. You don't want to use that mesh. And he was resistant. And she continued to stop the line and push. And eventually, he called another surgeon in the room and said, oh yeah, you can't use that mesh. And the patient was safer, the outcome was safe and good, but it took a little bit of a courage, on her
Mhm.
part, to also not just to escalate and say, hey, stop, but to also persist when she knew that that wasn't right. That stopping line, it's not a sign of weakness. It's really a hallmark of safety.
Yeah, that's a great example. And it also speaks to the importance of having kind of a team mindset across all the interprofessional team. And that, this culture of safety and this mindset that we take with that goes beyond just nursing. It's fostered across the whole hospital, though nursing plays a strong role in that, but
Yeah.
it's part of the culture as a whole, across all team members. So, um, I know you just gave an example. What it was, can you give us another example, maybe where you had a time in your career where you saw how culture of safety directly impacted outcomes, like for patient outcomes, or even for staff? But I know with your past experience and your leadership, there's probably been many opportunities for culture of safety to have an influence. But is there any one that's
Yeah.
particularly impactful to you?
Yeah, the hard thing's narrowing it down, right? There's
Mm-hmm.
lots of opportunities to learn from things that happen, but one that came to mind, and we've seen this in different scenarios several times. It's where especially in pediatrics, patient vital signs trend over time. So the heart rate may be slowly increasing over a period of even a day or two, and the blood pressure may be dropping just a few points over a period of a day or two. So it's more these subtle trends, and it's busy. I mean,
Mm-hmm.
that's the reality of work that we do. We have sometimes, 3 or 4 patients that are, really sick, need a lot of care, and it's hard to take the time to go and really assess these nuances of care that are really important for outcomes. And so we had a nurse once that was missed those trends, but thankfully did recognize them. Although, be it a little bit late, but did recognize them. Attempted to escalate again. I'm gonna, sort of use another example of that. Continuing to be persistent when you know you're right. uh, I work in an academic teaching hospital, so we have residents, we have medical students, fellows, we have lots of different trainees. And so she escalated to the resident that was on call, and the resident was, listened, but didn't really act and didn't follow through. She was still very uncomfortable. The next line is the fellow, and so she called the fellow. In the interim, the patient seemed to be becoming a little bit more unstable. So she
Mm-hmm.
actually activated our medical emergency team, which is, there's some folks have a stigma to using a MET team, or sometimes it's called a medical emergency response or MRE team. And so these teams really are there to help you immediately bring the resources you need to the bedside, other sets of eyes, other hands, people to bring materials so that you can begin to, help this patient and to help them through this situation. So they arrived, ICU consultant arrived at the same time, and they stabilized the patient, prevented a code, which is something you don't want to do. Obviously, outside the ICU, for sure, we track those. Actually, it's even an indicator of your performance. And the leadership response was really critical here, because the most important thing for us to do was to console the nurse. She was obviously devastated that this patient, escalated and had to be transferred to the ICU, but then
Mm-hmm.
also to review her workload and really begin to address the physician response. Why didn't we escalate? The nurse was escalating. Why didn't they escalate to their fellow or their attending sooner? And they really praise her persistence. So there's obviously there's opportunities to recognize sooner, but there's also opportunities to say, hey, you did a great job. You knew
Mm-hmm.
that this was a problem and you continued to persist. And really, the lesson there is not just escalation; it's recognition and escalation. And
Mm-hmm.
if it doesn't feel right, it likely just isn't right. And so
Right,
it's
right.
it's really worthwhile seeing that through to fruition, because at the end of the day, you want to go home and know that your patient was taken care of and is safe, and wasn't something that you go home and it sits in your mind and you're thinking,
Mm-hmm.
gosh, I sure hope he's okay tonight. Right? You want to follow that through to fruition.
Yeah, I think that's a excellent example. And yes, I always like to tell my students that the goal is to always leave our patients better than we found them at the end of the day. And so we certainly want to go home with confidence that that happened. And I think that even the topic of the medical response teams, I think even that in itself is a really good example of how over time, that is something that is culture of safety related that has changed. I know when I became a nurse, we didn't
Yeah.
have medical response teams.
Mm, me
And
either.
yeah, and so whenever those were kind of just starting when I was leaving working at the bedside, but they were an answer to a problem, which was patients when they're having those subtle changes or they're in on units that are not, the ICU where they have a deeper level, a higher level of support, I guess you could say, that we want to recognize those subtle changes, bring in a team of different experts, collaborate together, intervene before it gets to a point where it increases mortality risk, and other bad things from happening with patients. So that in itself, in my mind, is even a great example of how over time we've recognized that is not only a way to improve outcomes, but really the root of it is safety for the patients.
It is. Yeah. Yeah. I wish we'd have had those 30
Yeah.
years ago. I
Right.
would have used them.
Yes, absolutely. You and me both. So, okay, so let's kind of segue a little bit into specifically talking about the nurse's role in safety and preventing errors. So, every nurse has a role in promoting safety and preventing errors, no matter what our title or position is. It's something we need to take ownership of on a daily basis. So, how do you see nurses live this out in this responsibility on a day to day basis?
Well, at the end of the day, the nurses really are the eyes and the ears at the bedside, right? And so, one of the key factors that you should always do, especially in pediatrics, but I think this is true in adult care too, is you really need to know your patient, and you need to know those little bit of subtle changes, right? Is their personality changing a little bit? Are they more uh, you know, uh, quieter, reticent? Are they more somnolent? Is something different? And so, if you really know them and know them well, it's easy to start to pick up on changes when there are important things to know. So you really have to monitor them closely. It's not just about seeing the vital signs and knowing what the numbers are, but interpreting the numbers in the picture, right? And understanding what's going on with the patient and understanding what those numbers really mean and what the numbers are behind it. So it's that that second level of really thought
Mhm.
that's important. And then it's just following all those things that I think are we sometimes don't follow, but are really designed and implemented to keep us safe. And that's things like double checking, especially high risk medications, but
Mhm.
even double checking yourself when it's something routine and just making sure you got the right dose. And then using some sort of form of standardized communication handoff. That's required. Through some of our regulatory agencies here at Children's, we use SBAR, but knowing how to use that tool and understand what it means and how to give salient information that is efficient and not, so that someone's trying to tease through a bunch of details, but really gives them the information that they need quickly, keeps patients safe,
Mhm.
right? Because that's, one of the things that happens over time is we don't communicate well, and so that can lead to problems. And then just that same thing is, persist when concerns are diminished. If people aren't responding, just continue to push down the line, find the next person. And then, nurses are really central in preventing hospital-acquired conditions. I think,
Mm.
through our bundles, we have proven bundles that show us how to prevent central line associated bloodstream infections, how to prevent catheter associated UTIs or pressure injuries, falls, and a great example of that is we participate in a collaborative and started as the Ohio Collaborative. It's now called the Solutions for Patient Safety. It's really a pediatric focus organization where we don't compete on knowledge and we don't compete on best practice. What we compete on is execution. So we share what we know is best practice around these bundles or this algorithm or care guideline that we
Mhm.
know will prevent infections. So that everybody's can practice, has the opportunity to do the right thing. It's really about adhering to those and really executing and keeping your patients safe. So the success really comes from the execution, not just the idea.
Yeah.
It's really about going and following through and doing.
That's great. Yeah, I think about, when we teach our students all of the, I guess we could call them the proper ways to do things. They
Yeah.
go into the hospital and then they, they work with another nurse on a unit and they're like, well, wait a second, like this person skipped step 2, 7, and 8, like
Yeah.
what? Yeah. So we go into practice and then we see behaviors that are not aligned with following all those best practices.
Yeah.
We find the shortcuts, we, figure out ways to make life seemingly easier. However, that comes with a big risk. And I always like to go back to the fact that there is evidence to support literally everything that we're doing. So there's a reason why we follow steps 1 through 8 and we don't leave any out, right? So I think that's important. And if you don't mind, can you explain to us a little bit more about? I know you kind of started to go into the bundles as algorithms, but what are bundles when it comes to preventing those hospital-acquired infections or other unintended consequences for patients? And how did we get to those in the first place?
Yeah, sure. So, that's a great question. And I'll just say what you described just a moment ago through the just culture algorithm is at-risk behavior. It's
Mm-hmm.
drift, and we know what's right, but over time we begin to slip just a little bit from our adhering to our best practice, and we don't have a bad outcome. And it actually falsely reassures you that, oh, this is okay. They're not
Mm-hmm.
having a problem. I can continue to skip step 2, 5, and 7 because no bad outcome happens. But you're just being fortunate. Bad outcomes will happen. They're all part of the algorithm because they're important pieces to keep patients safe. And but that's at risk behavior versus reckless behavior where you're cognizant of what you're doing. Right?
Mm-hmm.
It's a human
Mm-hmm.
nature thing that puts you in that place. But yeah, so bundles, it's interesting. That's a fascinating question because back it's a long story, but I actually have had the opportunity to participate in several different research opportunities in children's, and one of the things I did in a long time ago, in 1997, was I did a study. And it was a line study on putting implanted venous access devices or portacaths in children with sickle cell anemia for chronic transfusion or even just for quick access when they're having a pain crisis or something of that nature. And they all got infected. The infection rates were incredible. So we felt like it probably had something to do with the fact they get sort of a splenic necrosis because of the sickle cell disease, and so they're asplenic. Their spleens don't function, so they can't filter out those encapsulated bacterial organisms when the blood flows through their spleen because it doesn't work.
Mm-hmm.
So we thought it was related to that. So we actually published and presented, a poster at a national sickle cell disease meeting on the high infection rates in implanted venous access devices in children with sickle cell disease. Well, the root of that problem probably was we didn't have bottles. We probably weren't washing our hands to the extent that we should be. We certainly were not using all of the different preps that we have now, like HIPAA and all those things that we were using now today. We didn't have those then. We really just kind of scrubbed things with an alcohol prep, and we didn't scrub the hub. So, now you scrub the hub for 15 seconds or so. I can't remember the exact numbers. And you, you're just much more attuned to, trying to reduce risk. You're wearing a mask, gloves, trying to be as safe as possible. We have little antibacterial discs that we can put around the needle side. And so it really, those infections were probably not, because I remember, early on thinking, well, these children, they're not immunocompetent. All of our kids with leukemia and the various cancers, their immune systems don't work because they're getting chemotherapy. Of course, they're getting infections. Well, they do get infections if you're not following the bundle. But
Right.
I can tell you, if you follow these bundles, you follow these guidelines and these steps, and you adhere to them, I have seen our oncology department go for more than a year with no central line infections in any patients at all because they're adhering to the bundle. Now, are patients less immunocompetent today or back when I was taking care of them than they are today? No, it's the same thing. We're
Mm-hmm.
just taking care of them differently. But and then not but it's about knowledge and learning. That's
Right.
another good example because we just didn't know.
Right.
We really didn't know. I mean, we washed our hands, but we didn't have hand gel. That didn't really exist. I mean,
Mm-hmm.
I'm sure it was here. I know we had some little containers here or there, but not to the pervasiveness that we have them now, where they're in every patient room. They're outside every patient room, and We have huge hand hygiene campaigns where, gel in, gel out. Every time you go in the room, you gel, and out, you gel. And then if your hands are visibly soiled, you wash, right?
Hmm.
It's just such a simple thing, we knew about it and we knew it was important, but not to the extent that it really is important. So
Right.
it's all
Right.
about growth and knowledge, getting better over time.
Yeah, that's an excellent example. So, one of the objectives that we have in this course comes from our AAC and Essentials, which establishes things that students must know when they graduate. And that is to examine how we understand the cause of errors, not just the outcome. So, we've talked a little bit about learning from our experiences, learning from what what we're observing. So, from a leadership perspective, what are some effective processes for identifying and addressing causes of errors?
Yeah, that's another great question. So obviously, if you're not familiar with it or you haven't participated, at some point you will participate in what's called a root cause analysis, and that's really where we come together, those that are closest to the event that occurred, along with some quality and safety experts, and we start to evaluate really step by step from patient admission to patient discharge. What happened along the way, and where could we learn, where could we get better, what did we perhaps not do well. The only thing about root cause analysis that I think I've learned is that it tends to fall and sort of end at, oh, the error was she didn't wash her hands, and then it
Mhm.
stops. Well, the reality is there's far more factors that contributed to that. Perhaps her assignment was more than was really appropriate for that day, or there weren't opportunities to wash your hand. Maybe there wasn't hand gel nearby, or there wasn't time to go do that, or maybe there were barriers that were physically in place that kept things from being able to happen. So it's really important that you do something now that's evolving and emerging, actually participating in a rate of reliability study around using human factors analysis and classification, or HFACs,
Mhm.
because it digs much deeper. It doesn't stop at the error. It says, okay, what was the staffing? How was the unit design? What were the policies that were in place? Did the policies keep you safe? What was leadership doing? What was leadership's knowledge? Was there cognizance that we were drifting from hand hygiene, and we knew our hand hygiene rates were lower, but leadership wasn't doing something to really intervene and to improve those hand hygiene rates? So it really reframes errors as more of a system failure, and takes it away from that individual blame, so that you're learning and you're going to create a safer system on the other end. So it's really all about trying to dig down and really identify and learn things that happened, not just the individual, but throughout the process.
Yeah, that's a great point. And I really like the highlighting the systems issue because I feel like, and I can't say put a number to it, but I would say, more often than not, there are systems that are in place that are just
Right.
not supporting an effective outcome.
Mm-hmm.
It also, it adds to that perspective of removing blame because the system as a whole is going to be multifaceted and have different areas where there's probably opportunities for
Yeah.
improvement.
Yeah. One of the systems that's most, I think puts us at risk at times is our electronic health record, because they're
Mm-hmm.
very, very smart
Mm-hmm.
and to, get overburdened with best practice alerts, or with, stop the line alerts. And we tend to become numb to those and blow through them. And so you
Mm-hmm.
have to really be judicious about how you use them, and make sure you're using them
Right.
not overly, overuse way that allows people to ignore them, and so that you really pay attention and can respond to them.
Yeah, that's a really good example because when you're busy and you've got a lot going on, you gotta, all you can think of is I gotta click through these five alerts so I can get to what I actually need to do when those five alerts might be something that actually matters. So that's a excellent example. In your experience, have you experienced or observed a situation where there was a near miss that turned into a learning opportunity? And can you tell us a little bit about how it was handled and what was learned from that experience?
Yeah, sure. I can give you an example of it's been a few years ago again, but it's really around a what we now call we didn't term them this then, but now they're called LASA or like sound alike medications, and it's
Hmm.
things like ketorolac and ketamine. And we had an incident where a physician ordered ketamine for sedation for a procedure, and the nurse administered the medication, um, but the patient didn't sedate. Well, it turned out it was ketorolac, not ketamine, and so it was really an opportunity to examine the workflows and to understand, where those medications were stored within an omnicell, were they adjacent to one another, and then one of the things that comes through some of the other regulatory bodies and just learnings over time is to use things like tall man lettering. So another drug, there's several drugs. There's lots of chemo. I did pediatric oncology for 25 years, so most of my references are going to be to that. But
Hmm.
um, vincristine and vinblastine. Well, they're such similar words, but they're different medications. And
Hmm.
so you, for vincristine, you bold and capitalize the VINC. Uh,
Right.
and for vinblastine, the VINB, right? So that you're able to distinguish between those two drugs. Another one is doxorubicin and daunorubicin. And so it's doxo and dono. And so you're really trying to help people be safe, even through those sorts of things. Another example is potassium chloride and keeping it safe and separate. We don't really keep, actually at all, we don't keep bulk um, potassium chloride on the floor anymore. We used to years ago, and we would dilute and create our own infusions. But now, thankfully, we've got pharmacies that do all that safe work for us. But they're color coded so that oh my gosh, I'm picking up something that's dangerous, and so you know immediately
Hmm.
that you've got it in your hands. And so I think the other thing that keeps us safe that people tend to, in sort of those best practice alerts, but tend to minimize how safe it keeps you is barcode scanning.
Hmm.
Is BMCA's, is scanning the patient's armband and then scanning the medications and then following those alerts if it tells you this is wrong, wrong timing, wrong drug, wrong patient. Really to help yourself keep safe. The thing that we've implemented just recently is through interoperability is the ability for our electronic health record to be integrated with our scanning and with our Alaris IV infusion pumps. So you
Hmm.
can scan the patient, you can scan the infusion, and the pump will set. You still verify those settings,
Right.
but it's a nice way you have fewer keystrokes, and fewer keystrokes means fewer opportunities for error. So
Hmm.
um, those near misses around medications are probably the most important thing that we have to learn from. One of the things that we learned a few years ago was it's been many years now, but Dana Farber Cancer Institute in Boston, there was a woman who was given a severe overdose of cyclophosphamide, a chemotherapy drug that just essentially disintegrated her heart. She died almost immediately. And so
Oh,
we
wow.
were so fearful that, we could perhaps make the same mistake that we went through what's called another way to learn about error. It's called a failure mode effects analysis, or an FMEA. And
Hmm.
it's really a fishbone diagram that is very detailed of a process down to every single minute step or sub step. And so we really came up with a process where physicians write chemotherapy orders. They're verified by a second physician. They both sign. Then the orders are verified before they're prepared by a registered nurse along with the pharmacist. And they're using the chemotherapy protocol to make sure that this is dosed correctly. And then before administration, there's two nurses that verify chemotherapy. So you wind up, getting six sets of eyes on every single dose of chemotherapy, uh, which you may think is excessive, but it's one of those where the narrow the margin of error is narrow.
Hmm.
So it doesn't take much to make an error, and the consequences of an error with a high risk medication like that are devastating. So
Hmm.
it's the right place. That's the other thing I just want to mention, is be sure that it's really easy to say, oh my gosh, she's a fantastic nurse. I trust her. I know this dose is right. I know she's drawn up the right amount of morphine. But you're double checking those high risk medications, not because it's just a step. You're doing it to keep her safe, the patient safe, yourself safe. And so it's really important because everybody can have a human error. So that's really, it's called redundancy. It's something that we're doing to help one another. It's not because we don't think each other is professional, or that we're really good at our job or we're discerning. It's just to help us not make a mistake.
Yeah, that's a great point, and I appreciate you pointing that out, because those steps are so important. As you're describing these situations, I'm remembering conversations I've had in different nursing leadership circles where we've talked about the fact that in the airline industry, there is zero tolerance for errors, right? Because you've got a plane full of people that you have their lives on the line. And we understand that humans make mistakes, but really for us from a healthcare perspective to have a mindset that we have zero tolerance for errors because of the consequences that it could potentially have to our patients really is very important. I think when we take that level of seriousness with how we think about it, it changes maybe how what our actions might be in response to that. So,
Yeah. Yeah, it's
yeah.
interesting. All of these, many of these things, like the human factors analysis and conditions that I talked about, that's all from the airline industry. So
Mhm.
all of these second verifications, second steps, these checklists, you maybe you've heard of the checklist manifesto, and having these opportunities to really make sure you've done everything and that you're just verifying and giving yourself sort of what I used to call a peripheral brain, right? You don't have to hold all that information here. You have it on a piece of paper or a checklist so that you can go through and make sure you're safe. I mean, it's all about that. It came from aviation.
Mhm.
You're spot on. And what's unique is you have to really put yourself in the patient's shoes and say, okay, I'm with this patient. I'm the pilot. They're my passenger, because the difference for a pilot is if the plane goes down, the pilot goes down too.
Mhm. Yeah, that's a
And
good
so
point.
there's some nice reinforcement for them to keep themselves safe as much as. But I mean, that's why we're all here. That's what we're all here for, and that's what we're doing. So nurses are very much the same.
Yeah, that's awesome. I always love when there's opportunities. I feel like in healthcare, sometimes we can be so tunnel visioned into what we do and the processes we use. And I love when I find opportunities where we learn from other industries, and it
Yeah,
works both directions, but it can definitely change, how we do what we do. So, all right. So let's transition a little bit into talking about your safe to heal triad and violence prevention, because part of that culture of safety is a physically safe environment when it comes to workplace violence and how and that's not just from I think well, I don't know, sometimes I go straight to patients and family members and how they treat the healthcare staff, but
yeah.
it's actually between colleagues as well. So you developed the safe to heal triad, and can you walk us a little bit through what that is and why you created it?
Sure. Sure. So I had an opportunity to speak on a panel of industry experts from at believe it or not, at a building owners management association conference, which is completely non-healthcare.
Right.
But it's a group of individuals that build, open, and manage medical office buildings and hospitals, all over the world, really. But certainly this was at Denver, so it was all mostly United States folks. But and I was on this panel with a safety expert, a an architect, an engineer, fascinating, and then myself. And my perspective was to talk about healthcare violence, and they were talking about all the ways to physically keep people safe. And um, it really that safe to heal triad came from that, because it's really, to me, it's three concepts. One is environmental design, and those are things like staff only circulation area. So it's sort of this back of house which, a lot of older facilities that just doesn't exist. But it gives you an
Mhm.
opportunity to be somewhat off stage and separated from, kind of the general public. Limited entrances into buildings. We used to build buildings so that anybody could come in anywhere. We thought about convenience more than we thought about safety. But for example, our hospital is, 400 177 beds or something of that nature. And we really have three physical entrances for the
Mhm.
public to get in, which is pretty phenomenal. And that allows you to really assess and understand the folks that are coming into your building. So that's really physical, safety. It's the ability to have clean, clear sight lines, be able to see around a unit, not have blind spots or places where, you can kind of be out of sight, out of mind to other people that may need to come to your assistance. And then another part of that triad is staff training. So, we've always had, I think we used PPMAB in the past, and we've always done some training around how to physically restrain or keep patients safe if they're harming themselves or others. But one of the things we really didn't spend a lot of time with, and now we do, is all of our staff go through 2 full days a year of um, essentially self-defense training. And then
Mhm.
it starts with identifying when someone's escalating, and then the techniques to de-escalate and to try to prevent, some sort of event from occurring. But then it's also about just self-awareness of your environment, positioning yourself so that you can safely exit the room without being trapped. It's how to, sort of position yourself so that you're not flat-footed and forward-facing. When it's a tenuous situation, you have the ability to quickly turn and exit. It's kind of like playing defensive back on a football team. You got to be able to
Mhm.
turn around and go back the other direction really quick. And it's really about just keeping yourself safe and knowing how to keep yourself safe. And then it's technology. And so, things are advanced to such a degree now that, we just didn't have these again years ago. But we do things like every person that comes into our facility has to present their driver's license, and they get their driver's license run against known offender databases so that we can identify potential evildoers at the front
Mhm.
door and not let them in, or only allow them to visit with a security escort. It's panic buttons, it's duress buttons. They now make duress buttons that are part of your badge, and you can push the
Mhm.
button on your badge and call for assistance. And it actually uses a RFID system that identifies where you're at in the building so people can get there and get to you quickly. Weapons detection now powered by AI. We always resisted that because we're a children's hospital. It's intended to be a sort of a joyous place to the extent that you can make it as playful and happy and fun as possible. And so there was never this a lot of strong desire for having metal detectors and
Mhm.
wands and people stopping people. And well, now there's this technology where you just pass through. You may not even recognize you've passed through these two bars that use AI to determine, even if you're carrying something that perhaps is not a weapon, it can determine if the risk of it being a weapon,
Mhm.
if you should be stopped. And so, the security officer is standing nearby, they have an iPad, immediately it shows the area of concern and who the person of concern was, so you can flag them and ask them to come over to what we call a deconfliction zone. The other thing that's really important about that, especially we live in Texas, so it's an open carry state, so lots of people are carrying weapons, and we don't know that they have them, but they do, and so it's a deterrent just at the front door. I can tell you, it's what they've told me is it's uncanny the number of people who get to that point recognize they're about to walk through weapons detection and turn and go to their car,
Mhm.
and then they come back later, and so it's really about keeping our buildings as safe as possible through those really three opportunities. And I guess I just hadn't until that talk really had the opportunity to recognize that there's really those kind of three main swim lanes, And unfortunately, again, we learned from tragedy. Obviously, we had a shooting here in the Dallas-Fort Worth area not too long ago, where two
Hmm.
healthcare workers were killed. And so, prior to that, we were not interested in any sort of weapons technology. After learning and recognizing, hey, it's here, it's happening. We got to do
Yeah.
what we got to do to be safe. So, some people call that a theft of knowledge. I've learned I didn't have to experience that, although all of us healthcare workers experienced it, but I didn't have to have that happen in my facility. I can learn from others and be
Sure.
better because of it.
Yeah, that's a great example. And I think, your triad and the way you're looking at things really helps to be proactive in creating an environment that's going to be safe for our patients, our families, our staff. And it's unfortunate that we even have to think about those things, but we have to be realistic about the world we're living in and the risks that are presented. And so
Yeah.
those are great ways to look at how we can create that safe environment, physically safe environment within the walls of the facility. So,
I mean,
um,
at the end of the day, the violence continues to increase. We want to be safe. Well, what we've found through, I actually oversaw our patient experience team here for the last couple of years. What we found from our patients and our families is they want to be safe too. So
right.
it's everybody's cognizant of the risk in in our society today. And what we used to think would be oppressive to have, weapons detection at the entrance is actually reassuring today
Mm-hmm.
to
Mm-hmm.
know that we're doing something and we're trying to get ahead of these things to keep the environment safe. And, really at the end of the day, nurses, you can't provide safe care if you yourself don't feel safe. You
All right.
have to be in an environment where you know that you're safe and can perform.
Yeah, 100%. I think that's a very good point. So, to that point, workplace violence is a growing concern for nurses. And many of our students have, heard about this, or it's been, unfortunately may have experienced some things in clinicals where they've already seen this topic come up in different ways. So I'm active in the American Organization of Nursing Leadership, and this is a crucial topic that has been and continues to receive major attention at the national level. So you talked about some of the workplace safety changes that stem from your Safe to Heal triad. Are there any other trends that you're seeing right now in terms of workplace safety to address those challenges, or just workplace safety challenges that exist in general that you're seeing that need attention?
Yeah, sure. So a couple of things, come to mind. I failed to mention, but active shooter protocols, run, hide, fight,
Mm-hmm.
which is what we use here. There may be other sort of off the shelf products that people follow, but it seems to be one that's easy to remember. And what's interesting is you need to take that a step further, and we do that here. So we'll come to your work environment and we'll assess your area and we'll say, okay, if you need to run, where are you running to? Do you know where your exits are? If you need to hide, where can you hide? Is there a place within your office or within your work area, within your offsite or offstage areas where you can hide? And if you were to have to fight, I mean, that's last resort, but what are you going to fight with, right? Is there a fire extinguisher? Is there, something heavy that you can manage? I mean, we don't want to fight, but we know that, that if that potential, possibility came to fruition, you want to be able to be confident in knowing what you would do, pre-think
Mm-hmm.
it, right? It's that muscle memory of knowing what you're going to do. And I think the other thing, we call them capes and burps here. I don't, other organizations, I think, are these are becoming more commonplace, but a cape for us is a de-escalation. So if you have a family member or someone who's escalating, you can tell they're becoming agitated or perhaps at risk of becoming violent. We can call for assistance so that we get someone there who's trained and can help to de-escalate and manage the situation and prevent something from happening. And
Mm-hmm.
then a BERT is essentially it's like a code team. It's the behavioral emergency response team where you can get security, our psychiatric consult nurse liaison, a psychologist, the administrative supervisors. You can get resources just like you might for a MET at the bedside to begin to help you immediately to resolve the issue and keep people and the patient safe, right? I mean, these patients, unfortunately, I don't see things changing anytime soon. I mean, I've talked about this before. When I started, it was just almost unheard of 33 years ago to have a patient that was essentially violent or,
Mhm.
that needed a what we call now a constant visual observation sitter. Those things it just didn't happen. But I think our society and our culture has shifted such to the extent that it's here and it's probably here to stay until we can figure out somewhere way upstream how to prevent it. But that's going to take time, right? And
Mhm.
so I think it's a different world, and we just have to be prepared to be safe and be able to function in
Yeah, that's a good point. Are there any other types of workplace violence that you can think of that we haven't addressed to this point that would be good to be aware of? We talked a little bit
Yeah,
about, somebody coming in from the outside, patients and families, anything else that you can think of?
sure. So, you touched on it briefly, and we talk about this. We're starting actually part of my patient experience strategy for the last couple of years. We developed something we're calling Game On, and it's really an acronym of how we want to engage and interact with our patients and our families, but it's really applicable to how we want to engage and interact. And so there's microaggressions, there's things that are really important to be aware of and to avoid that really are a detriment to care. So it can shut people down, make them feel isolated, feel like they don't have a team that's at their disposal or available to help them. And one of the things that we want to do, no matter what, at the end of the day, is we're all here together. We're all in this together. We're all one. It really goes back to, it's humans, right? I mean, we're all humans and we all want the same thing. We want, our families to be safe, our lives to be happy, and our children to grow and be successful. And so we're all here together and we have to support one another. It's really a detriment to culture when we are not nice to one another. And one of the greatest examples I know, and I don't even like to use the term, so I'm not even going to say it, but we have to be very nurturing and very supportive of our new graduates because they are our future.
Right.
And so we strive for that here. I'm sure other organizations are working on that as well because it's just intolerable to create a situation where someone is learning and becoming going to be a professional nurse and becoming, really, really knowledgeable in the work that they do, but they need time
Hmm.
and they need support and they need a culture that allows them to do that and do that in a safe way. Being ugly or responding in an appropriate way is just not tolerable. That's one of those things we just don't. There has to be a red line,
Right. Right.
right? There has to
Exactly.
be a place where you say, okay, that we don't do that. That's not going to
Yeah, that's great. And it takes strong leadership to draw that line and hold
happen.
accountable our staff to that, when those behaviors creep up, it's not tolerated.
Yeah,
we're not going to tolerate that.
yeah,
And we're going to have a level of accountability, not just from leadership to the staff, but amongst each other too.
yeah.
We're gonna hold each other accountable that that's the type of
Exactly.
environment we want to work in.
That's right.
Yeah, I was thinking that, we talk about the patient outcomes that are affected by unsafe environments. But, one of the things that's been so detrimental to nursing that I've observed over the past 5 to 8 years ish, maybe, would be the staggering number of new nurses that we lose within the first couple of years of practice. And I think a lot of that could be attributed to it's their overall experience in nursing, but definitely when you're in an environment where you do not feel supported, that does not
Yeah.
get you anywhere in wanting to
Uh,
overcome the other challenges that you might have. So I have a
I
feeling.
graduated. Fortunately, I did have an internship. It was only 8 weeks, but it certainly was more than, what other folks offered at the time. But now, obviously, our residency programs are a year long. Now it's common knowledge and common fact that you graduate and you're prepared to be successful and be safe and to do all the right things, but you need time to be steeped in culture and to understand the nuances of the work that we're doing and to be supported in a better way. Through those residency programs, our retention rate at 2 years and 5 years is, I think 2 years is 95% and 5 years is still over 80%. I mean, it
That's
makes a
fantastic.
difference.
Yeah.
And really, it's huge to find a place that's going to support you and help you grow and become, safe in your practice.
Yeah, that's those are amazing retention numbers. And maybe something for our graduates to think about is when many of them maybe at this point have already
Mm.
accepted new jobs, but something to ask in your interview, what type
Absolutely.
of, how is that tolerated, or how do you handle it, or what is the approach to, how we treat each other in this environment. So that's fantastic. So let's talk a little bit about safety design principles and national standards, because there are organizations and standards that exist across the board to try to hold everybody accountable for safe practice. So, safety is not just individual, it's built into systems. We talked a little bit about that in the environments that we're in. So, what are some safety design principles that you've seen make a real impact in your experience?
Sure. So, one of those is the Joint Commission's National Patient Safety Goals. So, I remember when those first came out. I keep dating myself, but they've been around. It seems like they've been around forever, but they haven't. And it's just foundational pieces that we just didn't do before, like standardized handoff. We didn't do that. Those things, sometimes there was even a taped report. I don't know if you ever had a taped report where you left the report on a tape recorder, and we don't have tape recorders anymore, but then the next nurse would come on and listen to the tape. And then you would just say, "Okay, have a good day." I mean, no question and answer. Don't ask me any questions. Just listen to the tape.
That's
Uh,
crazy.
but it's just so much different now, and even eliminating dangerous abbreviations like methotrexate, it's a chemotherapy drug. We always labeled it MTX, and physicians would write orders MTX, and
Mm.
well, that's unsafe because there's other drugs that could have a reference to, or MSO4 for morphine. It could be mag sulfate. I mean, who knows what you've just written unless you're writing out exactly what it is that you want. And then I mentioned the tall man lettering. That's really important. That's a Joint Commission requirement. Handoffs, the rapid responsive deterioration. I mean, those standards really drive our daily practice. It's changed what we do, how we do, hand washing standards, and just the fact that we have a cognizance and keep that at the forefront of our minds. Florence Nightingale just knew that it was really important for you to wash your hands. That was a long time ago, and to
Mm-hmm.
think that we didn't, really, um, you know, make that like a red line in the sand until the '90s is kind of remarkable, right? I mean,
Right, right.
we washed our hands, but not that much. And I remember our campaign started. It was when In and Out first came to the Dallas Fort Worth area, and so we coined gel our gel in, gel out, and then we had In and Out bring their trailer and make hamburgers for everybody, so we could
That's
reinforce,
awesome.
how important it was to gel in, gel out. But there's lots of different standards. There's to err is human, and that report and all the things that we learned from there, and just the creating that learning culture. One of the things that we've not really touched on in detail, but really is, I think, important is the principles of a high reliability organization, which is
Mm-hmm.
another sort of concept that's I think catching on and growing, and it's really underpinned by that just culture. You have to have a learning sort of slant to what it is that you're trying to do to keep patients safe, and those principles are preoccupation with failure. How can we fail? What could go wrong? How can we put things in place to keep ourselves safe? That reluctance to simplify, which I have to really battle against that because I just want to, okay, we fix this, we got it, right? And really, things are more complex than that, and there's more parts and more pieces, and so you can't just oversimplify. You've got to really work upstream and find all the things that perhaps attributed or contributed to that. Sensitivity to operations, which was always important to me when I was chief nursing officer over in Dallas, was that I really wanted to know what was happening day. There's policy, that's what's supposed to happen, and then there's practice, that's what does happen. And what's the difference, day to day? And so why is that? And if you look for the workarounds, most likely the workarounds, they may be the right thing to do, but the
Hmm.
workarounds are going to they're a symptom of something that's not right in your policy or your practice. And so you have an opportunity to fix things when you identify and know what those are. It's that commitment to resilience. It's saying that, we're going to be safe and we're going to commit to this and we're going to continue to improve and get better all the time. And then deference to expertise. One of the things that we cannot do is I can't sit over here, especially now I'm in an office building a couple of miles away, and say I'm an expert, here's what you should be doing. Right, the
Hmm.
experts are the people who are at the bedside doing the work every day. You've got to learn from the people that are experiencing it, feeling it, know what challenges that they're running into, and really be able to improve your system. You can't do it. It's not remote control. It's not work from home. It's you've got to be there in the midst and listen that are challenged with it every day.
Yeah, that's great. And with these standards that we have too, I think that the standards got bumped up to a new level too over the past 10 to 15 years when reimbursement started being more heavily tied to following certain standards of care too, and that changed some of the accountability for hospital organizations in how seriously they addressed or some of these issues, because it affected the bottom line. And so having those national standards can make a big difference, ultimately at the end of the day in patient outcomes, which is what
Yeah,
the goal is. So, um,
especially with Medicare and adult
right.
care. We don't do a lot of Medicare because
Mm-hmm.
it's not really for children. It's just end-stage renal disease and organ transplant. But it for us, it's this child's 4. You want to make sure that they make it to 84.
Yes,
And so
absolutely.
it's really there's an altruistic benefit to reason why we don't want to harm
Right. Right. That's an excellent point. So, let's see here. When we talk a little bit about reporting incidents, because this is we've touched on a couple opportunities where an error has been identified, or there's been a near miss, or somebody intervened in a particular step of the process to prevent the error. um, at the end of the day, reporting incidents is very important because otherwise we're not going to know where these errors happened or where there's opportunities for improvement. And I think that can feel kind of intimidating. I know for me, I think, I'm telling on myself or whatever it might be. There's that blaming aspect that comes with it. So what advice do you have that to give to students about accountability and reporting the necessity of it, especially if they make a mistake or that they notice something happened that was unsafe?
Yeah, that feeling you have, we all have, right? And we all grew up in sort of that punitive environment where an error is going to result in some sort of, admonishment or some sort
Mm-hmm.
of you've got to do something to get better.
Right.
um, and so I think it's really we need to change that culture. It's around the leadership response. So we have to. It's on us to embrace feedback. We can't get better if we don't know.
Mm-hmm.
Near misses are just a golden nugget. It's an opportunity to really become better and safer and have better outcomes. And so we have to really value people who step forward and give us that information. So we actually are as much as we trend our what you might call incident reports. For us, it's called a safety concern. But as much as we, follow those things, we also follow what we call good catches. And so we want to celebrate, and really organizations should be celebrating and say, hey, I am so glad you came forward. You just saved 100 lives or, over the next 10 years or whatever it is, right? Because you've put us in a better place. You've put, pediatrics in a better place. And so always report. Transparency is just absolutely essential. I mean, it's crucial. No one comes to work intending to harm. Our mission here is to make life better for children. Everywhere we come here, I mean, that's one of the beautiful things for me. And, for almost 34 years now, is we're all here working to make life better for children. Nobody wants
Mhm.
to harm someone, and so just know that errors happen, near misses happen, but they have to be reported, and there has to be a culture of that's free of fear or any sort of reprisal. And we just can't get better or improve if we're not getting information. I know it takes courage, but it's the right thing to
Right. That's a great point. And, having that courage, speaking up when necessary, at the end of the day, you can feel satisfied in knowing that the outcome is that your patients are safer for it. And so, yes, it's definitely something, to be
do.
encouraged by.
You want to be able to go home and go to bed and sleep without fear, without worry,
Right.
right?
Right.
I mean, so you do the right thing so that you know that you're not at home waking up in the middle of the night fretting or thinking, oh
Hmm.
my gosh, I hope that patient's okay, or I hope, you know, someone finds this or that doesn't happen again. I mean, it's
Yeah.
better to just get it off your chest and let people know
Yes.
and let's move on. Yeah.
Yes.
It's all going to get better.
Absolutely. Absolutely. Well, so let's kind of wrap up our conversation here. I have a couple questions to end our conversation. So we're in the final module of this course, and students are on their final countdown to graduation. I'm sure they know the hours and the minutes until they get there.
Exciting.
Uh,
Yeah.
so, what is your best advice for walking onto a new unit and contributing to a culture of safety right away?
Well, I think it's, be courageous, right? Be cognizant of the fact that you don't know everything. You're not expected to know everything, and you're there to learn, and that's good, right? The more that you learn, the better you're going to be as time goes on. Learn the workflows, speak up for safety. Uh, I don't know, most organizations have something. Ours, we have a badge buddy that's a safety no exception badge buddy that gives you all of these tools so they're easily referenced, like using AIDIT, ARC for escalating concerns, team member checking. That's really important, where we check on one another and we do this dual verification and we take that seriously. SBAR, QVV. I love QVV. As qualify the source, validate the content, verify your action, and then stop and resolve. Is okay, this doesn't feel right. Is this right? Am I doing the right thing? And just stop for a moment, pause. It's you just like you might stop the line for a surgery or something like that. You're stopping your own and checking your own self, right? Just to kind of think back through things. But really, the top two failures in healthcare for me, in my experience, really have been communication breakdowns. It's that, so talk, tell people,
Mm-hmm.
explain, escalate. If it's on your mind and you're thinking of it, share it. Don't know, that old adage. There's no dumb question, right? I mean, it's everything. Bring it forward, and then escalate. If you think something's not right, it's probably not right. Thank your colleagues, embrace those that are supportive of you, support your colleagues. So, one of the things I've always said when I was a nurse before is, if I was having a good day and I could see someone having a bad day, the worst thing you can do is sit back and say, wow, look at that. They're having a terrible day. I'm having a great day. The best thing you can do is say, I'm having a good day. Let me help. How
Mm-hmm.
can I help you improve your day? It's just all better at the end of the day. It's really about just building that safety culture.
Yeah, that's great advice. So, looking back over your career, what would you say has been the single biggest lesson that you've learned about safety, whether it's for patients, for your teams, or for yourself?
I think for me, it's really it's that culture of supporting one another and being open and transparent. I mean, that and then knowing. I mean, I touched on it earlier, but there was a time in my career where I did not think that immunocompromised children could be prevented from getting an infection. It is clearly proven to me now that you absolutely, it's related to our technique and our process and the things that we do. Sure, there's times when, maybe they, for some reason, they, drag their line through a bathtub that's contaminated, or, there's something in the air external to the building that they get exposed to a mold or a fungus. But Those are really rare. These central line infections are almost always related to cleansing and disinfecting and our technique, the way we change caps, and whether or not we're masking ourselves. So, for me, that's probably the number one lesson is that bundles work. They really
Mm,
do work. We just got to follow them. We just got to do the right thing. And you don't have to, come up with what the right thing is. It's there. It's published. It's, most likely your organization, we have them on the wall. So
yeah.
it's everywhere, right? It's easy to do the right.
That's awesome. And that's, I think a lesson that we can all learn from as well. So I appreciate you sharing that with us. So we've had a great conversation and touched on a lot of really important topics around safety, and your expertise has been extremely helpful. So I always promise students that I'll take some time to bring it back to the exam because at the end of the day, they want to pass their exams. So
Now the hard part, huh?
yeah, right. So if you don't mind, would you be willing to answer about three questions that help take
Sure.
the safety concepts and put them in the context of what they might look like on an exam? So
Absolutely. Now, I mean, just
awesome.
preface that it's been 30, let's see, 92, is that 33 years since I took the N class.
So
And
no,
it's on paper
yeah, yeah. So no pressure,
over
right?
2 days in a convention center with 1,000 other people.
That's too funny. Well, we'll try to make it I don't know. I think with your expertise in safety and culture of safety, I think you'll be able to do these well. So, okay.
Gosh.
You know what? Hang on. I have the wrong one up. Darn
Oh, I like that one.
it. Those were
Boundaries are big,
yes.
actually, especially in pediatrics. When I first started, I fell in love with every patient I took care of, and I
Mm,
still do, but I also recognize that, they're to keep yourself safe, especially if you're
yeah.
working with children that may have a bad outcome. You have to be really careful.
Okay, this is better. That one was for my
Oh,
professional
there's your
identity
answers.
conversation. And those are the answers. Okay. Okay, we're going to cut all that part out. Good thing I'm doing some video editing here. Okay. So, all right. So here's our practice question that we're going to get started off with. So, for this particular one, this is one of our new NCLEX style of questions. So you see here, there's a list of events, and then we're going to the stem of the question says for each event, specify whether the event is a sentinel event or a near miss event. And because I may have some listeners who are not watching but just listening, I'm going to go ahead and read out each of these events. And while I do that, you can think about which one you think is sentinel event and which one is a near miss. So the first one is a client fall results in a hip fracture. Second, an invasive procedure is performed on the incorrect body site. Then we have the nurse identifies an ABO incompatibility while obtaining a blood product. The nurse identifies a miscalculated dose when preparing medications for a client. A client admitted for suicidal ideation dies of suicide in the emergency department. And lastly, a client has an anaphylactic reaction to a medication that was documented as an allergy. So, would you let us know what you think? Are the which
Sure.
event is sentinel and which is near miss?
Yeah. So I'm not going to get the definition of sentinel that, off the top of my head just perfect, but essentially it's a unanticipated severe outcome. It could be death. It could be severe injury that requires extensive recovery or intervention, subsequent surgeries, things of that nature. So obviously, a client who I'm assuming here's a known fall risk who falls and has a hip fracture, that'd be a sentinel event.
Mm-hmm.
Invasive procedure performed on the incorrect body side. That's wrong side, wrong side surgery. Essentially, that's absolutely a sentinel event. Identifying an ABO incompatibility while obtaining a blood product appears to be before administration, so would be a near miss. And then identifying a miscalculated dose when preparing, obviously that would be a good catch. Both of those would be good catches, so near misses. And then any time that a patient that is at known suicidal risk, if they die of suicide in the facility, that's a sentinel event. And then The last one, I would say yes. If it's a known allergy to a medication and the patient has, and it is, despite that, ordered, goes through all of the double checking process and continues, and then is administered, the patient has an anaphylactic reaction, which is going to require resuscitation or some sort of subsequent extension of the stay or different medical intervention. That would be a
Awesome. Very good. You got all of those correct. So great job. And I appreciate your explanation of, your thought process along the way. And your definition of a sentinel event is very close to what I have. It's serious preventable error causing irreversible client harm or death. So, it doesn't have to just be death. It can be client harm, and it's irreversible. So we
Mhm.
definitely want to
Yeah,
prevent.
what's interesting, that's why, that last one I, sort of hedged just a little bit because when you do RCAs, it's irreversible. That key, sometimes people can say, well, the hip fracture will heal. Well,
Right.
it's still severe.
Right. But so without a very extensive intervention, it would be
Yes,
irreversible, right? Same thing
that's
with the
right.
allergy in the medication. We're gonna have to.
You had to intervene to save their life.
Exactly.
Yeah.
Exactly. Very good. So yeah, and just to give the official definition here for a near miss event, we're looking at a preventable event that is intercepted before harm reaches the client. And so that's a really important thing that it's before harm. So we want to remember that those sentinel events are unanticipated, preventable errors that cause significant client harm or death, and the near misses is when we prevent that from happening. So, a good reminder for students here. So, all right, next question. A nurse is preparing medications for 4 clients during a busy shift. The nurse realizes after administering one client's medication that the wrong dose was given. What is the best initial action the nurse should take? Is it A, complete an incident report before notifying anyone? B, monitor the client's vital signs and continue with other medication passes? C, immediately assess the client's condition and notify the provider? Or D, document the error in the medical record but not in the incident report?
Yeah, the most important thing is to assess the patient and notify the provider.
Yeah, very good. So that is correct. And I think these students I'm sorry, these questions pop up at times, and they can kind of feel a little tricky to students, I think, but the important thing is to recognize that we're looking for the best initial action, and we always want to make sure the patient's safe first, and then notify
Yeah,
the provider and intervene appropriately to keep the patient safe, and then we can go through those next steps of documenting the situation, the incident report, those types of things.
because there's little nuggets of truth in every all the other three too, but they're not
Right.
completely. Yeah.
Right. Yes, you will at the appropriate point complete the incident report. But that's after notification to the appropriate individuals. And likely you're going to include your charge nurse and other individuals in that process as well. Monitoring the vital signs. Absolutely. We want to make sure the patient's stable and show any changes that may take place. But we wouldn't want to just continue along like nothing ever happened. And then documenting the error is, there, and you might want to kind of expound on this a little bit. There, we want to document factually what has
Mhm.
happened in the situation
Yep,
in the medical record, but we're not going to put the incident report in the medical record.
that's correct. So you document in a very factual, short, descriptive way without any sort of judgment or opinions or even sort of opining about what may have contributed. Those are the things that you might put in the incident report. And
Mm-hmm.
incident reports are under essentially attorney-client privilege, so they're non-discoverable, and that's by intent so that organizations can safely report and learn from those near misses or errors. So it's intended to be that way so that you can share information and actually become safer as an organization. But yes, you don't want to hide things in the medical record. That's not right either. The right thing
Mm-hmm.
is to just factually, simply document what happened.
Yeah, very good. Thank you for adding that clarification because it's very important to know and to understand why we're not putting that information in there as well. So, all right, we have one more question, and it's a pediatric question. I don't even think I
Wow.
did this on purpose, so that worked out great. So, all right, a nurse in the pediatric intensive care unit observes a parent becoming increasingly agitated after receiving difficult news about their child's condition. The parent is pacing, clenching their fists, and speaking in a raised voice. What is the best initial action for the nurse to take? A. Ask another staff member to take over while the nurse immediately leaves the room. B. Use a calm, non threatening voice and acknowledge the parent's emotions while maintaining a safe distance. C. Call hospital security to remove the parent from the unit immediately. Or D. Continue providing care for the child while observing the parent's behavior.
Yeah, the answer here would be calm, non-threatening voice, acknowledge their emotions, maintain a safe distance. It's really about that de-escalation piece.
Yes, very good. That is
What's
correct.
fascinating about that one is that that is pediatrics, right?
Yeah.
Because parents, they don't, no one wants anything bad to happen to their child, and these emotions are really difficult to control. And if you're going through anything else in your life, it's probably going to be impossible to control your
hmm
emotions at some point. So that's a very common scenario. That's not
Right.
a, at all.
Yeah, yeah. And it's a great example, like you said, of an opportunity to use de-escalation. I mean, and when we look at the option choices to kind of understand why that one's the best one, if you leave without support, you abandon the client in that situation. And if there is any escalation, no one's there to intervene. The de-escalation technique that we're using here is that we're acknowledging the parent's emotions, speaking calmly, ensuring physical safety, which is really important, and that aligns with that those approaches that we have in place to prevent the workplace violence from happening, and using good trauma informed communication. With C, we may need security at some point if the situation escalates, but calling immediately without attempting any de escalation can actually escalate the problem in itself, and may result in other things like damaging trust with the family and interfering with the patient's care. And then for D, ignoring early warning signs of aggression risks the safety of the nurse, the child themselves, and then others in the room or on the unit. So,
Yeah.
yeah.
Yeah,
So
for
this,
us, I mean, the other key things here might be, a cape. I had mentioned that earlier. If you really need help to de-escalate someone, but short of a cape, certainly I would notify social work, give them an opportunity to come and see if they could be supportive to the family,
right.
or depending on the family and their beliefs, it could be pastoral care.
Mm-hmm.
But asking them, Kim, is there someone that I could call that you would like to talk to that may help
Sure, sure. Those are some great examples and, proper ways to handle that situation beyond just that initial response. So
you?
awesome. You made 100. You did a great job.
Oh, good.
Well, all right. This has been a wonderful conversation. And I have one last question for you that I like to ask all of my guests. So, the question is, what is the best advice that you've ever been given?
Well, for me, and it's interesting. It was given to me by she was the director of the nurse practitioner programs at UT Arlington at the time. She's now retired, but she's a PhD neonatal nurse practitioner, and she was my mentor when I became the director of the advanced practice service. When I was, really, I think, starting my career in leadership. And the advice she gave me was, and I still follow this to today, is it's sometimes easier to um, seek permission than it is to I'm sorry, to seek forgiveness than it is to seek permission. And so really what she was telling me is do the right thing, is take action and go forward, and not be paralyzed by fear of what may happen or may not happen. So a great example is if you escalate and you recognize the patient's deteriorating, yet you're wrong, well, that's okay. You've
Mm-hmm.
done the right thing. right? It's still okay. And if you report near misses or errors, it's still the right thing to do, and take action, be engaged, and be part of your system and your environment that's really striving to get better. And so, yeah, that's always been something I kind of keep in the back of my mind is, is take action, do things, do
Yeah.
what's right.
That's awesome. That's great advice and a great puts a nice little bow on our conversation today. So I really appreciate you for joining me today. Your insight and your stories have helped bring the safety concepts that we're learning to life in a way that the textbook doesn't. So for those listening, I know you're preparing for graduation, studying for final exams, and anxious to step in your first role as a professional nurse. So I hope this episode helps you to see that safety isn't just about following policies or checklists, but it's about culture and accountability and leadership in action. So remember that creating a culture of safety means advocating for your patients, supporting your team, and having the courage to speak up, even when it's hard. So these skills will serve you well on exams, but more importantly, they'll define the kind of nurse and leader that you become as you begin your profession. So thanks for tuning in to Leadership Chats with Dr. Wise. And until next time, keep learning, keep leading, and stay curious. Thank you.